Without motivation, things don't get done. And I needed quite a push to relive events and complete this documentary. I have a close friend who is a bit too tolerant even for my own tastes. During superficial surgery at the University of Washington in Seattle, a kiwi-sized chunk of her brain was destroyed. Doctors had attempted general anesthesia without blood pressure or BIS feedback, the most accurate measures of anesthesia depth. Even worse, this was done during IV drip anesthesia, where resuscitation is far slower than with gases. The most highly paid doctors are anesthesiologists. Whether working as an anesthesiologist, or flying a plane, or driving a car, you must keep your eyes open and pay attention to what you are doing. Because everyone responds differently to drugs, anesthesiologists must monitor drug effects on every patient. Otherwise, proper drug dosing is impossible. For thousands of years, it has been known that individuals respond much differently to alcohol. Lethal dose 50 is the drug dose lethal to half of a population. For alcohol, lethal dose 50 is 5 grams of alcohol per kilogram of patient. Drug toxicities can only be known statistically. Some will succumb to a fraction of the lethal dose 50, while others will tolerate many times the lethal dose 50. Rare individuals can drink and barely get drunk. To compensate for the varying effects of drugs on different patients, both state and federal law dictate that blood pressure must be monitored at a minimum once every 5 minutes. During my friend's surgery, the UW failed to properly monitor blood pressure for the first 74 minutes. Prior to 1903, safe general anesthesia was not possible, as blood pressure could not be accurately measured. As such, Civil War surgeons were not insane. They did surgery quickly without general anesthesia. So to make things right, the perpetrators rushed to the intensive care unit before it was even clear whether the patient would survive, implanting an important message into her damaged but attempting to recover brain. It could not be avoided. It was just one of those things. 2 weeks before the patient could even swallow soft foods or barely speak intelligibly, her damaged brain was implanted with their doctrine. According to an anesthesia article by the Wall Street Journal, the University of Washington conducted the most comprehensive computer study ever, allowing anesthesiologists to duck responsibility. Clearly, it was the unconscious patient's fault for overreacting to an intravenous injected super stimulant. Then, to keep their victim on the defensive and in their control, the UW aggressively pursued billing demands over the better part of a year, just like Michigan State University did with the raped Olympic gymnasts. This was not one of those things. It was action-reaction. R and Char kept trying to say that their patient had had a stroke from out of the blue. No, it was cerebral hemorrhage caused by drug overdose. It was action-reaction. just as striking someone's head with a bat starts cerebral hemorrhage. During superficial lip surgery, a stable anesthesia level was never attained. Not prior to surgery, not even 65 minutes past the start of surgery. Over a 50-minute period, a constant anesthesia overdose was administered. Anesthesia overdose causes diffuse brain damage due to a lack of blood flow. Blood pressure being too low to push blood through the vessels. Then next, an overdose of stimulant was used for emergency resuscitation. Hypertension, cerebral bleeding, and greater brain tissue destruction resulted. With actual blood pressures pulsing radically between 100 and greater than 250 millimeters, with each and every beat of the heart and for several minutes, you had ideal conditions for cerebral hemorrhage. The anesthesiologist never even acted to pause the procedure and assess for brain hemorrhage. Drug toxicity being the same as the effects of high doses, ephedrine toxicity presents as brain hemorrhaging, particularly with intravenous injections. And when used with sevoflurane, ephedrine is many times more deadly. This toxic effect was further aggravated by high phenylephrine dosing. Crystal meth is made from ephedrine. Even meth addicts are afraid to inject the stuff, and if they do, they know to never go and lie down. So my friend received the maximum allowable 5 milligrams per milliliter dose of ephedrine. And if the doctor grew annoyed and injected this too quickly, this alone would have been devastating. But the UW refuses quality assurance. They release no surgery video or audio, no accounting of drug vials administered, and no doctor drug testing results. The heavily redacted official UW medical record omitted vital sign data entirely, instead showing tiny, incomprehensible graphs. So then, it took 6 more months to obtain the less redacted raw data set, and even this data was easily falsified. This data was stored in Microsoft Excel format, which even a 3-year-old could change. Hospitals truly concerned about quality of care, or the slightest concerned about patient well-being, do not issue heavily redacted medical reports. When asked about the timing of drug administrations, the UW Anesthesiology Department Head, Dr. Alan Artrew, said the timings were only approximate and might have been off by many minutes in either direction. Artrew didn't know anything about which anesthesia machine or blood pressure cuff was used. In short, he cared nothing about what his staff did or anything about their patients. Patients, apparently, being something less than human. Those who are above the law never get held responsible. Artrew worked hard playing dumb and concealing the truth. So in the end, almost nothing is known about which drugs were given and when, or whether a drug dose was even reported at all. They might as well have said in their official UW medical report, "We drugged okay, we drugged them good, we drugged okay, we drugged okay." Doctors will always claim to only treat patients in good faith. Yet the medical record reports only the trivial, saying nothing of the life-threatening low blood pressure emergency, nor the succeeding life-threatening high blood pressure emergency. Hospitals that truly care anything about their patients will admit to medical emergencies. Lacking a proper medical history, how could subsequent doctors provide proper care? The outcome was nearly fatal brain swelling, yet a third unreported medical emergency. Before giving any dose of a powerful stimulant directly into the bloodstream, any anesthesiologist must be thinking, I better be careful not to overdo this. I must avoid cerebral hemorrhage. Instead, it was nearly 3 hours before the University of Washington acknowledged and started to treat this brain hemorrhage.
A brain hemorrhage is a life-threatening medical condition, and it is crucial to receive medical treatment right away.
Let alone CAT scan imaging, they didn't even pause the procedure for EEG or BIS. Earlier in the procedure, BIS had been disconnected for convenience. Since excess anesthesia causes brain damage from oxygen deprivation, and hypertension will completely destroy chunks of the brain, or often kill, the University of Washington must have expected some brain damage during this surgery, but just hoped it wouldn't be too noticeable. But by working to conceal mistakes, they willingly inflicted ever greater injury. Each of 3 different hemorrhage treatments would have all improved the outcome. And if the brain hemorrhage had been realized and the procedure halted, not one person in the operating room would have been paid by insurance. And furthermore, the University of Washington would have had no leverage against the patient for unpaid medical bills. Although true, having a family presence in the waiting room does decrease bad outcomes by 3-fold, you can still not blame anyone but the doctor when there's goofing off or politicking. How dare they dishonor a God? She would show them, she would slay, then resurrect. Video recording of surgeries, rather than worshipers in the waiting room, would best put an end to politics. And given the 3 times worse outcomes, should it even be legal to tell doctors who waits outside of the surgery? Doctors too seldom have to face up to the truth, because doctors very rarely testify against doctors. Instead, they gang up on patients. So why face up to the truth when you know your colleagues are more than eager to support your lies? Dozens of UW records even call this a post-operative cerebral hemorrhage. But there was absolutely no evidence of this. There was never any repeat of any hypertension. Furthermore, a post-operative hemorrhage would have had little or no brain damage. Take Montel Williams, who got treatment within a half hour of his brain hemorrhage. Montel had a great outcome. Montel was not left lying flat for 3 hours so brain tissue could swell and die. While lifting heavy weights during an intense workout, Montel Williams burst a vessel near the top of his brain.
Don't go to sleep and don't lay down.
So what'd you do?
And I mean, literally, I could barely move. I stood up and grabbed onto the walls.
This image showing the peach-sized bleeding in his brain.
Then there was Dr. Bria Sparrow, who gladly sold herself to support Docs R and Char. Dr. Sparrow states the patient's blood pressure appeared to briefly be in excess of 180. But the physiology of the patient and apparatus used indicated blood pressures in excess of 250. That could have been much higher. Even veterinarians know this. Oscillometric blood pressure monitors are more commonly known as cuff-type blood pressure monitors. Cuff blood pressures are inferred from oscillation envelopes rather than directly measured. These inferences cheat toward normal blood pressure, 120/80. Such systems are termed undersensitized or biased. So for low blood pressures, these cuffs report falsely high, and for high blood pressures, these cuffs report falsely low, cheating toward 120/80. But for women, the cuff errors are greatest. For people with large arteries, the cuffs work best. But for thin-armed women with small arteries, systolic errors may be extreme. When systolic and diastolic pressures vary markedly, the oscillation envelope is greatly stretched and drawn thin. These extreme conditions occurred within my friend when heavily dosed with powerful sedatives and then powerful stimulants. At best, small female arteries can only produce a weak oscillometric signal. Thus, the signal-to-noise ratio is insufficient to correctly define the oscillation envelope. Measurement noise pinches off the ends of this poorly defined oscillation envelope, causing grossly low systolic readings. Even veterinarians know this. No algorithms or signal processing can possibly repair a situation where there is insufficient signal compared to background noise. Any forthcoming anesthesiologist could write a booklet on how these cuffs operate, rather than just playing dumb. It is pressure differential that explodes buildings during a tornado, squishes divers, and ruptures arteries. These cuff systems cannot see spikes at all, but rather average pressures over many heartbeats. When systolic and diastolic pressures vary greatly, the system averages pressures over dozens of heartbeats, causing even greater inaccuracy, as every heartbeat produces a somewhat different blood pressure. Dr. Sparrow further states that due to the patient's young age, vascular malformation possibly caused the brain hemorrhage. While this might be true for children, clearly a 46-year-old is no child. It is just back to the old game of blaming the patient, even when drugged and unconscious. Dr. Sparrow and all those jumping on the bandwagon reporting a post-surgery brain hemorrhage were willing to terrorize the patient and her family, letting them think a second deadly hemorrhage could happen at any time. One even told her she needed to get her children checked. The most extreme blood pressure spikes that this 46-year-old patient ever realized came on December 16, 2016, as a direct result of an intravenous ephedrine injection, while at the same time being heavily doped with phenylephrine, sevoflurane, fentanyl, and other powerful capillary dilating narcotics. Capillary dilation causes blood pressure to crash between each and every heart pressure pulse.
But that's better than finding out everything was a lie.
This hemorrhage in the base of the brain, nearest the heart, very strongly suggests just one thing: an acute intravenous drug overdose. These extreme spiking blood pressures drop quickly within the plumbing, moving up through the brain. Multiple findings ruled out aneurysm and vascular malformation. Jones-Taylor's falsehoods were soon revealed, as even 2 UW doctors admitted that hypertension caused the brain hemorrhage. Yet it was Jones-Taylor's falsehoods that the UW stuck at the front of their phony baloney official medical report. So even though blood pressure soared in excess of 250 millimeters, blood pressure fell all the way back to 100 millimeters every time the heart filled and prepared to beat once more. These dramatic pressures caused a hammering effect on the vessels, much like what plumbers refer to as a water hammer. Vessels flexed violently wherever they curved or bent. Bending and flexing materials break. So within the basal ganglia, the part of the brain nearest the heart and subject to the highest pressures, cerebral hemorrhage resulted. Then, just 20 minutes following the 2 emergencies, like so many doctors before her had done, Dr. R abandons her patient mid-procedure, all the while her patient's brain swelling and tissues dying. Then, the University of Washington medical records were falsified or at least doctored. The official version of the UW medical report shows a 0.4% dose of sevoflurane. Sevoflurane multiplies the toxicity of ephedrine. A more detailed, most difficult to obtain, raw data set shows that a 4.3 times higher dose of sevoflurane was actually truthfully given compared to what the redacted official UW medical report states. It is peak sevoflurane dosing that sets blood plasma levels, as sevoflurane lingers many days in the body. While sevoflurane may be rapidly expelled from the lungs, the sevoflurane blood plasma half-life lasts for many days. The uncontrolled partial emergence from general anesthesia causes a dangerous arousal, producing life-threatening blood pressure spikes. This patient required 2 quick emergency doses of propofol to put her back down. An average blood pressure value is reported without any diastolic or systolic readings, which should be impossible unless the data was doctored. The software rejects such data, then immediately remeasures. The record falsely claims unable to use BIS monitoring because interferes with surgical field. Electric fields interfere with the high impedance BIS inputs, not the opposite. BIS wasn't used because the anesthesiologist was in a hurry or maybe playing games. The UW refuses to release any records of their internal investigation, even to the patient, for this very rare, one-time in 40,000 incident, leaving the UW able to alter and falsify their internal investigation up until the time it is finally made public. The impact-sensitive blood pressure cuff had been installed directly in the surgeon's path, being repeatedly bumped. The anesthesiologist determined the placement of the blood pressure cuff. The UW medical record reports moving the blood pressure cuff from the wrist to the ankle at 4:14 p.m., fully 74 minutes into the procedure. Fitting the cuff to the ankle would have required a larger cuff, but simply moving the cuff, as the report states, would have led to major errors. The report clearly states that the cuff was moved. Because the cuff gave consistent readings only when on the ankle, it must have fit the ankle and been very loose on the wrist. Loose cuffs being highly sensitive to impact. Only after the near-death vital sign crash was the cuff moved so that it could produce useful readings. Early on, the cuff read nonsense. Only after reinstallation did the cuff read like connecting the dots. Early on, the cuff was set to read once every 90 seconds, but kept returning grossly corrupt values. More than half of the time, the readings were discarded as corrupt. Thus the erratic interval between readings. An alarm would have sounded with each rejected reading. Many of the accepted readings were corrupt in reading falsely high, as the cuff deflation cycle ended prematurely. The cuff thought the impacts from the surgeon were blood pressure pulses from within the patient. Nurses always tell you to hold still when reading your blood pressure.
Okay, let's start the measurement. Try to remain still and calm throughout the measurement. If you move or get excited, your results won't be accurate.
After inflation is finished, you'll feel a decrease in pressure. However, keep still until the display shows the final results, because the unit is still measuring your blood pressure while it deflates the cuff.
Press the power button. Do not move and remain quiet during the process.
Having high standards, even for deathly ill patients, Baylor University discontinued a heart transplant program when survival rates fell below 80%. Having very low standards, even with a healthy young patient, the University of Washington ignored a nearly fatal, one time in 40,000, medication-induced intraparenchymal hemorrhage. Although a poorly installed blood pressure cuff and failure to monitor patient vital signs triggered this series of events, a desire to conceal the truth multiplied the fallout. And if you're not somebody important with attorneys at the beck and call, in the United States this treatment is typical.